We'll see how time looks. Okay. So I want to just kind of go through some of the muscles here of the axial skeleton, and then we'll finish up the appendicular skeleton with the labeling today. So let's start off with the muscles of the head and neck here that move the head and neck. All right. So when we're talking about the muscles on the front here and the sides, the anterior lateral portion. Basically, and if you think about it, it makes sense that if they're on the front, that when they contract and they get shorter, they're going to pull your head down. So they're going to flex your head and neck forward. And one of the big muscles that does that is going to be the sternocleidoid mastoid muscle. As you know, it originates or it attaches onto the sternum and the clavicle there, more to the midline, and then onto the mastoid process of the temporal bone behind the ear. So when you get both muscles contracting at the same time, a bilateral flexion of the neck will occur. But when we get one muscle, okay, like say we get the right sternocleidoid mastoid muscle contracting, what you're going to do is basically, if I'm contracting the right, I'm going to look down and away, okay? So we call that lateral flexion because it's going to be what we call ipsilateral lateral flexion, which means I'm contracting the right muscle, I'm going to laterally flex my head to that same side, and then I am going to move my chin towards the opposite armpit, my left armpit, so down and away. So we call that lateral flexion to the same side, or ipsilateral lateral flexion, and rotation, all right, to the opposite side. All right, so my head's going to rotate to the left side. All right, so the scalene sisters here, the anterior, middle, and posterior scalene, again, they will work with the SCM, the sternocleidoid mastoid muscle, to flex the neck. When we talk about inspiration and breathing, okay, they help to elevate and pull, all right, the first and second ribs upwards, okay. Well, actually, pull the first and second ribs upwards during a deep breath, all right? But they'll also help to forward flex, all right, the cervical vertebrae towards the first and second ribs there on the lateral flexion side there. Okay, so just kind of a quick review. Here's the sternocleidoid mastoid muscle, all right, with the two attachment points, the clavicular attachment, the sternal attachment. Then you can see parts of the scalene muscles deep to that. All right, muscles on the back of the head. Again, they're going to extend the neck, so looking up towards the ceiling. All right, the main muscle that's going to, or the most superficial muscle, is the trapezius muscle, okay? And again, with the trapezius muscle, it manipulates the pectoral girdle quite a bit, all right, because of its attachment site onto the lateral portion of the scapula there. It will do some neck extension. Splenius Capitis, again, we're not responsible for Splenius cervicis or semi-Splenius Capitis and Longissimus Capitis, but for Splenius Capitis, the one that we're going to be identifying for the test, okay, when we contract both left and right Splenius Capitis, you'll get neck extension. But when we do just the one, all right, like the right Splenius Capitis, then we get rotation, all right. If I contract my right Splenius Capitis, just the one, I'll turn my head to that same side. We'll get ipsilateral rotation. So you turn your head to the same side of whatever muscle that you're going to contract. Suboccipital muscles, again, these are a group of muscles that you don't have to identify. They sit right there at the base of your skull. All right, it's going to be these four muscles. You got 1, 2, 3, and 4, and they form a triangular-like configuration there at the base of the neck there. And these muscles are highly responsible for headache pain, believe it or not, because this area, C1 and C2, are highly innervated with several nerves in the area, and if those muscles go into spasm and whatnot, they can cause some headache pain. Erector spinae, these guys travel the whole length of the spine. We used to call them in school the I love spaghetti muscle group. Iliocostalis, longissimus, and spinalis, right? Their job again is they're going to be the deepest group of muscles that run on the posterior portion of your back and just lateral to the spine, right? Their main function is to maintain upright posture, okay? So if you bend over and you go to straighten up, when they contract, they will extend the vertebral column. If you lean to one side, all right, lateral flexion, all right, you will contract just one of the erector spinae muscle groups on that ipsilateral side. Quadratus lumborum, this muscle group we saw that connects onto the bottom rib 12, and it connects from rib 12 onto the transverse processes of your lumbar vertebrae 1, 2, 3, 4, and 5, and then onto the posterior portion of the iliac crest. All right. Mainly, they help with upright posture also, but when you bend over, you go to straighten up, you are going to extend the vertebral column. All right. If you laterally flex one of the quadratus lumborum muscles, you'll lean to that side. You'll have that ipsilateral unilateral contraction there. So we can see some of these muscles down here. Here's the erector spinae muscle group on the back side, and then your quadratus lumborum muscle group is going to be right here, located on the posterior portion of the iliac crest, attaching onto rib 12, and then the transverse processes of L1, 2, 3, 4, and 5. All right, muscles of respiration. It's important that you understand some of these because you're going to revisit them when you do the respiratory chapter, okay? But, so I won't get into the actual physiology of inspiration and expiration, but for the most part, inspiration, taking a breath in, is the active contractile portion, and then expiring or breathing out is the relaxation of the muscles. That's a relatively passive process. Now, when we're dealing with forced inspiration and forced expiration, taking deep breaths in and forcing breaths out, it's a different story, okay? So basically when you are taking a breath in, you'll be filling the lungs up with air, okay? So when the muscles contract, they're going to increase the size of the thoracic cavity because the ribs move out away from your body like a bucket handle. You're lifting the bucket handle up. And then just the opposite occurs during expiration, all right? The muscles will then relax that you use to inhale the air, but we get a decrease in the thoracic cavity size, and that is going to force air out of the lungs. Okay, so the muscles that we're going to see on the front and the back of your thorax, your chest there, right? You've got the serratus posterior superior and the serratus posterior inferior, which, wait a minute, here you go. Here's the serratus posterior superior and serratus posterior inferior, okay? Now these muscles up here, the upper portion, are going to help to elevate the ribs, okay? So serratus posterior superior is going to help with forced inspiration. Serratus posterior inferior, all right, is going to help with forced expiration when you're trying to move the air out, all right? The scalene muscles, all right, attach onto the first and second ribs. So when you contract those muscles, they help to elevate the first and second rib. So they too will help with forced inspiration. Okay. Our external intercostals will elevate the ribs up and out during a regular inspiration. All right. You do not need to. Those muscles, along with the diaphragm, are going to be used just as you're sitting here in class. You're using the external intercostals and your diaphragm, all right? But when you start to get into forced expiration, you're going to be using the posterior serratus posterior inferior You're going to also use the internal intercostals for forced expiration. Transversus thoracis, which is that muscle that sits here on the inside of your rib cage that we saw, all right? Transversus thoracis is right in here. It usually goes from one rib to like 2 ribs above, okay? Here are the external intercostals, and that's going to be for regular inspiration. The internal intercostals are going to be for forced expiration. Our scalene muscles here, you can see that they attach onto the first and second ribs. Those will also be used for forced inspiration. And then you got the diaphragm. This is the big one. This is the guy that, again, you're going to use just with normal breathing here. And so when you contract the diaphragm, normally it's like a big dome when it's relaxed. But when you contract it, it flattens. And when it does that, all right, it's going to decrease the pressure inside the thoracic cavity, which is going to allow air to pour into the lungs. It's a pressure thing. You get to learn about pressure gradients next semester or whenever you take 211. All right. All right. A couple things with the muscles of the pectoral girdle. All right. Pectoralis major and minor. Pectoralis minor, you don't need to know. That's the one that's deep to major. Okay, it's going to attach onto ribs 2 through 7. All right, it's actually another muscle that is used during forced inspiration. All right, but this is the muscle that gives us this appearance here with the hunched shoulders here. So most of us, as we're getting older, or if we start to have bad posture because we're on our phones a lot or on the computer a lot, when this muscle tightens up, it pulls the shoulders forward, okay? But its normal functionality is to help to pull the scapula downwards, but unfortunately, all right, when this muscle gets tight, it protracts or pulls the scapula away from the spine and forward, which gives us that forward hunching there of the shoulders. All right. Serratus anterior, this is that one that's going to be underneath your armpit here, okay? Its job is to protract and stabilize the scapula. There's a nerve that innervates this muscle. It's called the long thoracic nerve. Oh, excuse me, not the long thoracic nerve, the internal thoracic nerve. Anyways, this nerve is, I won't say frequently, but it has an increased possibility that if it is severed, especially if they're removing lymph nodes from the axilla or some of the lateral lymph nodes for breast mastectomies. If that gets clipped, it causes the muscle to become paralyzed, and you'll get what's known as winging of the scapula. You know, as your scapula normally lays flat along your thorax. If they clip this this nerve, they don't literally pop off, but the medial border comes off of the back because the serratus anterior helps to protract and keep the scapula pulled against your rib cage. If this muscle gets injured somehow, then it's no longer able to stabilize the scapula, and you'll see what they call winging of the scapula, and the medial border just kind of flicks off. Here's a good picture of pectoralis minor. Again, we're familiar with pectoralis major, all right, but pectoralis minor is deep to that here. And then you can see here's serratus anterior. And you can't really see it on this model here, but it wraps around, serratus anterior wraps around, and it attaches onto the medial border of the scapula here. All right. Some of the posterior thoracic muscles like levator scapula, rhomboid major and minor, and trapezius. All right, levator scapula, right, attaches the not the anterior, but the superior angle of the scapula up to the mid and upper cervical vertebrae here. And so, again, obviously by the name, we can figure out that it elevates the scapula, but also it allows the inferior rotation of the scapula. So it'll pull, all right, it'll pull this inferior angle, this little point down here, out. It moves the scapula out that way, all right, almost like a lateral rotation, but when it comes to the scapula, we call it inferior rotation, okay? Rhomboid major and minor, right? that is located here in between the vertebra and the scapula on the medial border side there. So again, if you look at it, all right, it's going to help retract or pull the scapula closer to the vertebral spine. All right. It'll also, because of the angle of the muscle fibers here, all right, they go up and in. So if we contract both rhomboid major and minor on both sides, it will help to elevate the scapula superiorly. And then trapezius muscle, if you look here, it's got a whole bunch of different actions. Elevation, it's going to give you that shrugging motion, the upper fibers, because if you see here, we've got upper fibers, middle fibers, and lower fibers. And it really depends predominantly which fibers are actually being activated. Here's the levator scapular muscle too, I didn't point that out, attaching onto the superior angle here and up to the upper cervicals there. But with the trapezius muscle there, depending on which region that you're really contracting, like for elevation, that's going to be the upper trapezial fibers. When we depress the scapula, that's going to be primarily the lower trapezial fibers. Retraction, and that's going to be the middle fibers. Okay, and then again, same thing when we're dealing with rotation of the scapula, it's really going to determine or depend on which of those fibers that you are contracting. Is it the upper, is it the lower, is it the middle fibers there? All right, latissimus dorsi and pectoralis major. These folks here are going to influence, all right, the glenohumeral joint, okay? Specifically when we're dealing with, all right, for latissimus dorsi, that's going to be when we're doing pull-ups, for example. So when we're doing pull-ups, it's going to cause extension of the arm. Your arm is moving back. Remember, extension of the a long bone is when we increase the angle. All right, we're going to be moving away. So the arm extension is going to be moving our arms back. We're also going to have adduction. We're going to bring the humerus closer, all right, to the midline. And then medial rotation is basically, all right, bending the elbow and turning the arm out. So all of those will occur, all right, when you're contracting the latissimus dorsi at the glenohumeral joint. Pectoralis major, again, this will help with arm flexion, so we're going to be bringing the arm forward. It also adducts, and it also medial rotates, just like latissimus dorsi. And the interesting thing is, latissimus dorsi and pectoralis major, right, both have very similar insertion points onto the humerus. Right, one inserts just medial to the long head of the biceps brachii muscle, and then the other one will go lateral to the tendon of the long head of the biceps brachii muscle. Okay, you can see they're very similar, except latissimus dorsi is going to extend the arm, while pectoralis major is going to flex the arm. Triceps brachii here, all right, primarily is an extender of the glenohumeral joint, but it's also going to adduct the arm, pulling it closer into the vertebral column. Okay, biceps brachii is on the front of the humerus, so it's going to offer flexion of the arm. Okay, this is just when we're dealing with the glenohumeral joint. All right, we haven't talked about what it does at the elbow. Okay, deltoid abduction of the arm, pulls the arm away. Okay, now deltoid is similar to trapezius, that it has different fibers. Okay, but in this case, deltoid has anterior fibers, lateral fibers, and posterior fibers. So if they're on the front, all right, in addition to abduction, all right, they're going to offer flexion of the arm, okay, and it helps to turn the arm inwards or immediately rotate the arm. Whereas the lateral fibers are straight, just abduction, and then the posterior fibers are on the back, so they're going to help to extend your arm backwards, and then also they're going to laterally rotate the arm, moving the arm outwards, okay? Coracobrachialis, teres major, all right? Those two muscles here, again, when we're dealing with the glenohumeral joint, coracobrachialis attaches onto the coracoid process, all right, and then it inserts onto the humerus. That's going to offer, because it's on the front, all right, that's going to offer flexion primarily, and it's going to give you some adduction, so it helps to move your humerus closer to the midline there. Teres major, we saw that on the posterior portion on the back side. So since it's on the back, it's going to offer extension of the glenohumeral joint. It too will pull the arm in towards the midline, but because it's on the back, but where it attaches onto the humerus is on a medial anterior portion, it will turn the arm in. Okay? All right, our rotator cuff muscles, you can see here, all four of them. Remember our sits muscles, S-I-T-S. All right, subscapularis, supraspinatus, infraspinatus, teres minor, and subscapularis. Subscapularis sits on the anterior portion of our scapula, attaches to the medial portion of the humerus, so it's going to immediately rotate the arm in. Supraspinatus sits on top there of the spine of the scapula, and it attaches over the top of the head of the humerus. All right, its tendon goes over and attaches onto the lateral portion, all right, by the greater tubercle there, and so that gives us abduction, helps to move. Actually, the first 15 degrees, all right, first 15 degrees of abduction of your shoulder, the primary mover is supraspinatus. So a good way to determine if supraspinatus is torn or injured or whatnot, if you're trying to determine if you have a rotator cuff tear, because supraspinatus is the most often muscle in the rotator cuff to be injured, right, is just have the person just start to raise their arm, abduct it. And if they have a lot of difficulty within the first 15 degrees of moving it away from their body, then it's supraspinatus. It won't be it might not be the only muscle that's injured, but it's definitely involved. Infraspinatus and teres minor are so close to one another, all right, that they have pretty much the same muscle actions. They're going to adduct, so they're going to bring the arm in, and they attach onto the back side of the humerus, right, on the posterior portion there, so they're going to turn the arm out. Okay? We call that lateral rotation. All right.
If someone goes to, I've always done this, so if you go work out and you're doing like squats and lifting weights and patting that on, and that's 24, 40 hours, it's really, really sore. Is it true that what's happening is you're tearing your muscles a little bit, or is it just?
Well, if you're tearing the muscles, there's a possibility, and it really depends on the type of soreness there. A lot of it just has to do with that, again, you have a lot of metabolites that have poured into that muscle tissue, and they haven't been cleared out. But essentially what you're doing is when you're exercising your muscles, when they increase in size, you're going to eventually be increasing the number of contractile proteins that you're going to build. But when you first go and exercise, a lot of that has to do with the chemicals that are released into the muscle tissue, that it's causing that irritation to the nerves. And so when the nerves get irritated, they're setting up a reflex there, in which they're, I don't want to say shutting down the muscle, but it's causing a lot of those that, again, when we get into the cross bridge formation there that occurs, right, a lot of the time it will shut that down, and because we're not getting those cross bridges to release. Most times, there's a couple different reasons, but there is a possibility, and especially if it's somebody that's not trained or knows how to exercise properly, that when they go in there and they go, like, for the first time, and it happens quite frequently, where someone's like, I've never exercised before, or I've never lifted weights, so I just went to a gym and I started working out, and then the next day I was dying. There is a possibility that they may have caused some superficial strains in which they've damaged some of those cross bridges, those myofilaments. But as to whether or not they've actually torn like a muscle where you could see it, yeah, you could have what we call micro tears. So you can damage the actual cells themselves.
So I haven't ran in a couple of weeks. I get out and I run and whatever. The next day, it usually takes 24 to 48 hours. I'll be sore.
Sure.
So, I just always heard that, when you're working out intensely, that it's kind of slightly tearing the muscles to build them.
It can be. The whole building part, don't think of it like because if you're tearing the muscles to build them, don't think of it like that. You're going to, two things can cause that issue. One is you can have like lactic acid accumulation in the muscle, which we've all experienced that. And then the other one is when you get those micro tears, those microfibril tears, where you've actually damaged individual muscle cells, and then they'll start to repair themselves. Most likely you won't get scar tissue, you won't get fibrosis, but you can get fibrotic-like tissues where the actual cells will damage the connections in between the cells, and they'll start to stick to one another. So that endomyosin, you damage that, and now you'll get the cells, they kind of stick to one another. That will cause some of that stiffness that you're talking about. So when you start to go and stretch and work out, you're literally breaking up. They call them fibrous adhesions, and you're breaking those that sticky area there down until that epimyosin is able to, or excuse me, the endomyosin is able to reestablish its division between the muscle cells there. Yeah. That was a long explanation of that, but I'm sorry. That's the stuff I kind of like. Okay. So let's talk about here about the elbow joint here in the forearm. Okay. So we're talking about the upper portion of the upper extremity, okay, the brachium. All right, we like to break it down into compartments. All right, so easy to remember. The front compartment is going to contain the flexor muscles, the anterior compartment. All right, so these muscles are going to cause you to bend your elbow. Okay, they are supplied by the deep brachial artery. Not so much to worry about that, but the musculocutaneous nerve is the nerve that will supply the flexor muscles of the anterior compartment of your arm. Those are the muscles that bend your elbow. So that's going to be your biceps brachii muscle and then the brachialis muscle. Those are the primary movers or elbow flexors. On the back side is the posterior compartment. That's going to be our extensor muscles. Okay? Those are going to be innervated by the radial nerve. Okay? Also, we're going to see, all right, the deep brachial artery, all right, which is a branch, which is basically a continuation of the axillary artery, okay, which is a continuation of the subclavian artery. So these muscles, all right, are pretty much the triceps brachii, which are going to straighten your elbow. All right, so a couple of the muscles on the anterior compartment, biceps brachii, we name it because it is a two-headed muscle, all right, and it inserts onto the front of the humerus there. Its primary motion is to flex, but it also causes supination of the forearm, okay? So your palms facing forward, all right? The brachialis, all right, this is that muscle that we saw that was deep, and we saw it from the lateral view, is deep to the biceps brachii. This is the one I was telling you about, is the most powerful flexor of the forearm. This is the one that bends your elbow the best. And then here's the beer drinking muscle, brachioradialis. This is the one that's actually located on the forearm. I told you we use the brachioradialis to divide the extensor and flexor compartment on the forearm, okay? And so it also helps with elbow flexion. So here we can see some of these muscles here, all right? Here is the superficial, all right, biceps brachii, the two heads here. Okay, you can see the long head attaches onto the the coracoid process here, all right, and then just, oh, sorry, I misspoke. The actual short head attaches onto the coracoid process. Lateral to that is the long head there. And then deep to that, you can see here's coracobrachialis attaching also onto the coracoid process, attaching anterior, midway down onto the humerus, and then brachialis, this is the one that is responsible for most of the flexion of the elbow here. And that's mid-humerus attachment, all right, going down here and attaching onto the ulna. All right, onto the posterior compartment, the arm extenders. All right, you can see the triceps brachii, and we saw anconios briefly, but we didn't talk about what it did. All right, it also helps to straighten out the elbow. All right, biceps brachii, its main job is to help straighten out the arm or extend the humerus, but it also offers extension, all right, of the glenohumeral joint here. And again, triceps, because we're talking about the three heads that are involved, which I'll show you now. All right. So we have the long head, the lateral head, and the medial head, okay? So you've got your lateral head here. If you're looking at it from the posterior view, all right, the medial head kind of peeks around, all right, but the long head is also going to be on the medial side here. it's often confused that people think the lateral and the medial head are directly next to one another. That is not true. The lateral head will sit to the, obviously the lateral portion, then the medial, then the lateral long head will be medial to the lateral head. So I'm confusing myself with saying that. All right, let's wrap up here, and I'll do the forearm here real quick, and then we'll do some labeling. All right. Getting into the elbow joint when we're talking about the forearm, we got the Pronator Teres. You don't need to know, well, for identification purposes, for the Pronator Quadratus, all right? But again, the name tells you the action of the muscle, right? So the Pronator Teres is going to help the ulna pronate, or actually turn your palms down, right? The Pronator Teres is located in the anterior compartment. It attaches onto the medial epicondyle. Right? You have this muscle here. Again, we don't have to know it for class for identification purposes, but supinator, again, this is another muscle that we actually tell you what it's doing. This is going to be the muscle that's located in the posterior compartment of the forearm that helps to supinate, all right, or have our hands appear in the anatomical position here. So here you can see, all right, when we're in the supinated position, okay, you can see here is the Pronator Teres muscle, all right, coming from the medial epicondyle, crossing over onto the radius here. Okay, it helps roll that hand down, all right, for pronation. So when this muscle contracts, it flips the radius across the ulna here. All right. Right. Part of it is due to this joint here. You can't see it, but it's where the radial head articulates with the capitulum. The capitulum is that ball-like structure, and then the radial head has a little indentation and it swivels. And so that creates the swivel point. So when this muscle, and also it's helped by the fact that we have the interosseous membrane also acting, because it's made up of that dense regular connective tissue, and so it helps to keep both the forearm, both the radius and the ulna parallel to each other. Even though it's crossing over, all right, they're not bunching up on each other. So and they both, well, they don't both, but the radius swivels literally on the capitulum as it's pulled over. Notice the ulna doesn't really change because it's got that kind of like this type of configuration, all right, onto the trochlea here, okay? So it's great as a hinge joint of just flexion and extension. Most of that occurs, all right, at the ulna trochlear area there, but it's the radius in the capitulum that allow for that swiveling, that pronation and supination, just because of that. Yeah, it's really cool. I know it's hard to wrap your head around when you first think about it, but the majority of that is due to the capitulum and the radial head there. Yes, ma'am.
What about people who are like double jointed in their arms? Like I'm really double jointed.
Like, are you talking about like the elbow or the shoulder thing?
Yeah, my elbow.
Yeah, so with the double jointing there, it just means that, you know, those ligaments and the capsules that surround a lot of those synovial joints, you have a little bit more give there. I mean, it's like when you talk about double jointed, I've seen it with the thumb. Yeah, you just have incredible joint laxity, you know. And so it's just, and again, will it make you more prone for dislocations and things like that? Possibly when you're older, but if you have, remember, I mean, stability and mobility go hand in hand, you know. So you know, a lot of times, you see it, for example, for the knee replacements. You know, they found that prior to a knee replacement, if you strengthen your muscles all around the knee, then you can add stability to the joint. Same thing with you. You have a little bit more joint laxicity, all right? But if you strengthen the muscles, that will increase the muscle tone there, which will increase the stabilization, and you'll lose some. You'll probably always still be double jointed. Yeah, well, I know. I've seen some really interesting stuff out there. All right, let's just wrap up here and talk about lateral epicondylitis, and then we'll do some labeling here. All right, so tennis elbow, okay? On the lateral epicondyle, that is going to be, all right, where the extensor tendon is going to attach onto. All right, so that means pretty much all these muscles on the back side of your forearm, the extensor muscles, are going to be not affected, all right? But and a lot of times if you're doing a lot of wrist extension, which we see a lot in tennis, especially for, I don't play, all right, but like for backhands, if they're doing a double backhand, or when they're coming back to whip their hand back to come forward and slap the ball forward here, all right, they're going to be exercising that common extensor tendon quite a bit because they're using the extensor muscles there. And so just like any type of itis, it is an irritation. So when we talk about lateral epicondylitis, basically it's a fancy way, or saying tennis elbow is a fancy way, all right, of saying that the common tendon for the forearm extensor muscles has constantly been irritated, and you've got, going back to what Candace said, you get some micro tears in the tendons and in some of the muscle fibers there, because the weakest spot of a muscle is when it transitions from the actual muscle tissue itself into the tendon. All right, so say this is all tendon here. This area here is the area that's most prone to injury. And it's because we're transitioning from the muscle tissue to that connective tissue. And we quite frequently see that when there's micro tears, all right, in the tissue, it'll be right in that area there. And so that's what we see here with a lot of our our tendonitis type of issues, is that it starts where they transition, and then depending on how bad it is, it puts abnormal forces and stresses onto the tendon, and then the tendon itself. I mean, if you're tearing or damaging tendons, all right, the amount of force that you're putting on that tissue, because remember, tensile strength of a tendon is similar to steel that for the Achilles tendon, which is the largest tendon in the body, the strongest tendon in the body. So in order to get the tendon to be damaged, you are usually exposing it to repeated, constant, what we call overuse or repeated microtraumas. And that's, what are those microtraumas? Contractions. Constant, repeated, forceful contractions will cause that.
When you go in there, my husband had, he had the elbow surgery.
Mm-hmm.
What are they going in there to do to the tendon?
It depends. Like my brother-in-law had, I can't remember if his lateral, if it was the common extensor or if it was the common flexor tendon. I want to say it was the medial one. They had to go in there, it literally ripped away from the bone. It depends, because what the issue is, it's actually more common for the tendon to rip the bone away because it's so strong than to actually get severed itself from that. So you can have, like I said, you can have, here's the muscle again. So some of the sites, and then here's the bone, let's say. Okay, so you can, it depends. You can have a problem here at the attachment site of the tendon onto the bone. You can actually have the problem with the tendon itself somewhere, or where I was saying, where the muscle transitions into the tendon. So there's 3 different sites in which you could have a problem. My brother-in-law, for his, he had a problem here and here. He never had a problem here, which is crazy to me. He may have, and it just resolved and turned into scar tissue. Who knows? But he had, I think, 60% of the tendon was frayed and damaged at one point. So they had to pretty much sew it up. So it really depends. You'd have to ask your husband. I'm sure the surgeon has that, or he probably knows the information. Oh, it didn't? The surgery? Oh. All right. Well, let's do some labeling. Let's rest our brains here and finish up with some labels. So if you want to grab your atlas and pull that thing out, we'll finish up here with the lower extremity. All right, so we're going to head up towards the proximal portion of the lower extremity, and zoom in here. Okay. So you can see, and we saw this before, okay, when we were talking about the axial skeleton, or skeletal muscles, the axial muscles. All right, the psoas major muscle is lateral to the lumbar spine. And And we're just going to review this on a couple different models here because we're going to talk about the Iliopsoas muscle, which the psoas major is part of. So here's the psoas major. Okay, you can see it on this model here. Again, it's proximal to the upper extremity, or excuse me, to the lower extremity, but it's lateral to your spinal column. All right, so here is the psoas major muscle here. Does anyone know what page this is on? 44? 44. Okay. So here's the psoas major on both. Now we're going to talk about the iliacus muscle. Okay, here's iliacus. Sits in the iliac fossa, okay, of the os coxa, the anterior portion there. So you can see it on this model here, and then going back to page 44, you can see it here. Now what's going to happen is these two muscles are going to meet up and fuse together in the in the lower extremity. So this right here, you don't know this for identification purposes, but this is called the inguinal ligament, this right here. And this is what we use to determine, okay, as an anatomical landmark, inferior to that or below that, psoas major and iliacus have fused together to form the iliopsoas muscle here. All right, and the iliopsoas muscle is one of your hip flexors. Helps you to bring your knee up toward your chest. All right, so this diagram you can see, or this model, if you go medial to iliopsoas, you'll see these vessels here and a nerve. Okay, those are the femoral artery and the vein and the femoral nerve. Okay, so if it's blue, it's a vein, so that's the femoral vein. All right, then the femoral artery and then the femoral nerve. Well, we call that the VAN, vein, artery, nerve. And it goes medial to lateral. So the vein is medial, the nerve is lateral. I use that as an anatomical landmark because we're going to talk about these muscles over here that are medial to the VAN. So if you hear me say VAN, you know what I'm talking about. All right, so let's go to the backside, all right, to our gluteal region and talk about the largest muscle that we're sitting on right now, and that's the gluteus maximus muscle. Right? Its main function is for hip extension. So if you're standing up and you bring your leg back, okay, as far as you can, like you're about to kick a ball, right, you're utilizing the gluteus maximus muscle. This muscle is the primary muscle that helps you to climb up the stairs, believe it or not. Here it is on this model. I am not sure what page that's on. Does anyone have a page number? 33? 33. All right, so here you can see the gluteus maximus muscle. Now, just to point it out, it's not labeled, okay, but just in case you see it on a test, that's the sciatic nerve right there. Okay, you can use that as a landmark too, because we're going to talk about a muscle that's closely associated with that. All right, but that's the sciatic nerve, longest and largest nerve in your body. All right, and then here is another model, okay, the gluteus maximus muscle. Does anyone know what page that's on? 39. Okay. So those are three different models that you can see the gluteus maximus muscle from. Okay, so there's a muscle that's superior to it. It's similar in what it does to the hip for what the deltoid does to your shoulder. So the deltoid muscle abducts, well, gluteus medius abducts the hip. So that's this muscle here. Okay, it's the gluteus medius muscle. Now there is a gluteus minimus muscle, but we're not required to label that. Okay, so there's gluteus medius, it's right above the gluteus maximus. Here it is on this model. Okay, so we've dissected away gluteus maximus, so gluteus medius is right below. All right, and then we also have it on one more model here. Gluteus Medius, this is on page 33. You can see a really nice version here of the sciatic nerve just coming out, going down the posterior portion of your thigh. All right, well, since I'm talking about the sciatic nerve, I got to talk about the muscle that's right above it, and that's the piriformis muscle. Okay, so this muscle is an external hip rotator, helps to turn your foot out, but it sits right above the sciatic nerve. So if this muscle, there's a condition called piriformis syndrome. If this muscle goes into spasm or is injured, okay, it can press in the sciatic nerve and mimic sciatica. And it freaks people out. Here you can see the piriformis here on this model on page 33. So you can see just how it can impact. If that muscle starts to go into spasm and press on that nerve, it'll pinch the nerve. There's actually a small percentage, and I can't remember if it's 1% or 3% of people that actually will have, when they're born, the sciatic nerve pierce right through the muscle belly of piriformis. So they're always having problems. Small percentage, though. Okay. Iliotibial tract. This is, all right, a fibrous band of tissue that runs in the lateral portion of your thigh. Some people have called it the IT band. You cannot when you're labeling it on the test. You have to call it the iliotibial tract. Okay? But again, it's interesting because the iliotibial tract blends into and fuses with the capsule for your knee. So somebody could be having issues with muscles up in the hip, all right, but have knee pain and not even know why. And so that's why it's important that if you have knee pain and you can't figure it out and they attribute it to the iliotibial tract, then they have to investigate the muscles up in the hip. Because you can see, and we're going to see one of those muscles right now, it attaches onto the iliotibial tract, and that's this guy, the coffee muscle. Tensor fascia latae, okay? This muscle, you can see it attaches onto the anterior superior portion of the iliotibial tract. All right? So now what we're going to do is we're going to go back to the anterior view here. We're going to talk about some of the muscles on the medial side of your thigh. So the first one that we're going to talk about is the Pectineus muscle. That's this little muscle that we're seeing right here. I'm outlining it for you right there. It is medial to the van, specifically the femoral vein. Pectineus is medial to that. Helps to adduct the leg, pull it in a little bit. All right, it's in the medial compartment, so most of the muscles in the medial compartment, their primary motion is adduction of the thigh, of the hip. Okay, it will cause internal rotation of the foot also. Okay, now what page is that on? 38, 38. So the next muscle in is this guy here. This is the adductor longus muscle. Now, yes, there is an adductor brevis, but you're not responsible for that for identification purposes. It's deeper, okay? But the adductor longus muscle is just medial to the pectineus. So what we're going to do now is we're going to rotate the leg, okay, a little bit, and we're going to look at it from the medial viewpoint. So here's adductor longus from the medial view. And so I'm sure you can figure out what this does, all right, simply by the name. Okay, it's going to adduct the hip. And it offers a little bit of hip flexion. Okay, so there's adductor longus. So now, all right, we're going to go to another adductor muscle. And you can see here you have adductor magnus. So this is Adductor Longus right here, just for a point of reference. So Adductor Magnus is on the back. Again, obviously, we can tell what it does. It's going to adduct the hip. Does a little bit of hip extension too. All right. And there's a muscle in between. It doesn't have adductor in its name. It's just all by itself, gracilis. Okay. Nothing too crazy, just known as gracilis. Okay, so gracilis sits in between the two adductor muscles. Adductor longus is in front here. Adductor magnus is posterior or behind it here. Okay, gracilis is right in the middle there. Okay, I'm going to look at the thigh again from the anterior view. And we're going to talk about sartorius. Sartorius here is lateral to the van. Here's the van. All right, so it's lateral to it. This is Iliopsoas that I'm putting the X on. Okay, so sartorius is lateral to Iliopsoas. Sartorius is the longest muscle in the body. You can see it. It crosses all the way in front of the thigh, goes down on the interior medial portion of the thigh, all right, and it inserts onto the medial portion of the knee here. That's sartorius. So it helps you to cross your leg, like if you're sitting there reading the newspaper, okay, and that's the motion that it does. It helps to flex the hip, turns the knee out, bend the knee. All right, sartorius. All right, so now talk about our quadriceps muscle. Okay, ooh, scary. Quadriceps, all right, is talking about 4 muscles that sit on the anterior portion of your thigh, all right, and it helps with hip flexion and knee extension, straightens the leg. Okay, so the first one here that we're going to see, and this one is the most anterior muscle, okay, is the rectus femoris muscle. For my tests, you don't have to write down of the quadriceps. Okay, you can just write down rectus femoris muscle. Oh yeah, or yeah. All right, so rectus femoris. Now this is from the medial view. Now let's look at it from the anterior view. Okay, you can see it's right there on the front and center. Okay, rectus femoris muscle. All right, now we'll rotate the leg one more time and we can look at it from the lateral view. There it is. All right, so you should know this. You should be able to identify it from all 3 views. From the medial view, from the anterior view, and from the lateral view. It's the most anterior muscle of the thigh. Okay, it's the most anterior muscle of the thigh. Okay. So now let's talk about the muscle that is on the inside of your thigh, another quadriceps muscle. This is the vastus medialis muscle. So it's in between rectus femoris here, here's rectus femoris, and sartorius. Okay, squeezes in between there. All right, so you can see it from the medial view and the anterior view. Here it is from the anterior view. All right, it's on the medial side of your foot, or excuse me, of your lower extremity. How do I know? I look down at the foot. Where's the big toe? There it is. It's on the inside. All right, it's on the same side as the toe, so I know I'm on the medial side. So that's vastus medialis muscle. Okay. Now these 2 slides are relatively the same. If you look, here's rectus femoris, and on the previous slide, hey, it's gone. Okay. And we'll talk about that in a second why. Okay, same thing. All right, so if we have a vastus medialis muscle, we have to have a vastus lateralis muscle. Here's the vastus lateralis muscle. Okay, it's lateral to the knee. Okay, it's on the lateral portion of the thigh, and it sits in between the rectus femoris muscle and the iliotibial tract. You can barely see the iliotibial tract here, but there it is. All right, so here, let's put in the rectus femoris muscle there. So here's rectus femoris muscle. Here's the iliotibial tract. All right, it sits in between both of those structures. That's vastus lateralis muscle. So now we'll look at it from the lateral side, and there you go. All right, so that's 3 out of the 4. All right, quadriceps means 4. So the 4th muscle, which is deep to rectus femoris, we dissect away rectus femoris, and here is the vastus intermedius muscle. All right, now granted, that's not muscle tissue there. Okay, that's like a tendinous sheath, like almost like an aponeurosis type of structure. The muscle tissue itself is around it here, up here. Okay, but it's basically pointing to that structure that's part of the muscle. All right, so that's vastus intermedius. Okay, so let's go onto the back side of the lower extremity, onto the hamstrings. Okay, so we have 3 muscles that we need to know. All right, the first one, which is most lateral, okay, the most lateral muscle is the biceps femoris muscle. Right, and again, if you're not quite sure where it is, you can look at this zoomed out version. Here's the gluteus maximus muscle. All right, there's the spine. Here's the iliotibial tract. Okay, you can't really see it very well, but the toe, the little toe, is over here. All that's on the lateral side. Okay, biceps femoris muscle. Go ahead. Oh, the hamstrings? No. Oh, yeah. I should have said that. Nope. This right biceps femoris muscle.
What about right lateral knee?
No, you don't even have to tell me if it's the left one or the right one. All right. Yep. All right, here it is on the lateral view. Okay. And it's just posterior to the iliotibial tract there. That's the biceps femoris. Okay, there's 2 other muscles for the hamstrings. All right, they have a very similar name. The first one here is called the semitendinosus muscle. Now, it's really hard to see because, all right, I'm going to try to outline it for you. Okay. There you go. It's actually not too bad. Okay, so that's the semitendinosus muscle. And you notice there's only one arrow pointing to it. So the semitendinosus muscle down here at the distal end of the muscle, it sits on top of another muscle. It's a flatter muscle that's deep to that. All right, that's the other muscle that you're going to label. So what I tell folks is if you see an arrow pointing down here and the hamstrings on the medial side, if it has one arrow, it's semitendinosus. If it has 2 arrows, that's the semimembranosus. The membranosus is the flatter muscle that the distal portion of semitendinosus sits on. So here's semitendinosus again. Okay.
Those are the bigger muscle under it.
Bigger muscles, it's more flat. Yeah, the semitendinosus has a longer tendon there. All right, that's it for the thigh. Now we're going to move down into the leg. Okay, we're going to talk about the muscles on the front and the back of your leg. And on the side. because you do have 3 compartments to the leg. All right. With the leg, you have the anterior compartment, the posterior compartment, and the lateral compartment. So we'll start with the posterior compartment. The most superficial muscle of the posterior compartment is the gastrocnemius muscle. Okay, gastrocnemius muscle attaches onto the Achilles tendon, also known as the calcaneal tendon. And it's a 2-joint crosser, which means it crosses the ankle joint and it also crosses the knee joint. Okay, so that's the gastrocnemius muscle. And then, well, let's show you the tendon here. There's the calcaneal tendon. You can also call that the Achilles tendon. All right, so there's another muscle that shares that tendon, all right, and that muscle is called soleus. So the soleus muscle is the muscle that you use more when you're walking, okay, that's on the posterior compartment, and then gastrocnemius is more for like jumping, explosive movements. You still use gastrocnemius when you're walking, but mainly soleus, okay. Believe it or not, soleus is actually named after a fish. Have you ever had sole? Has anyone ever had sole? S-O-L-E? It's not a bad fish. Has anyone ever had orange roughy? That's a very tasty fish. Okay, so here's soleus from the lateral view. Okay, so since we're on the lateral view, let's talk about the muscles of the lateral compartment. There's only 2 of them. Okay, now you can use either name. It's really up to you. Okay, you have Fibularis Longus or Pectineus Longus muscle. Okay, Fibularis because the fibula is the lateral bone, all right, in your leg. So there's 2 of them. Okay, so Fibularis Longus is the one that's more superior, and then it tapers down, and then there's the tendon to it here. Okay. So it has this long tendon here, here. So there's a smaller muscle here on either side of the tendon, closer to the ankle, and that's called Fibularis Brevis or Pectineus Brevis. It is on both sides. So again, it's just hard to tell with the contrast here, but we'll try to outline. There's the tendon coming down. Yeah, so brevis is on both sides. Both sides of those blue lines. All right, so that's Fibularis brevis or Pectineus brevis muscle. Okay, now let's go to the anterior compartment. We're going to come back to the posterior side here in a moment. But let's go to the anterior compartment and talk about everybody's favorite muscle to give them shin splints. This is Tibialis Anterior, or you can call it Anterior Tibialis. It is just lateral to your shin. Okay, so Tibialis Anterior or Anterior Tibialis. Now what we're going to do is we're going to, well, let's stay on this side and show you the next muscle, extensor digitorum longus, which is just a little bit more lateral. Again, if you look at the name of this muscle, you can probably figure out what it does. Extends the toes. You do have a brevis, but that's down on the foot, and we're not responsible for that for labeling. Okay? So extensor digitorum longus is lateral to anterior tibialis. All right, just to show you, here's anterior tibialis again. All right, so now let's roll over the leg and look at the deeper muscles of the extensor of the posterior compartment of your leg. Okay, so you can see you got flexor digitorum longus. That's on the back side of the tibia. You can see it. This is from the medial view here. So it's deep to soleus. Here's soleus right here. Okay, gastrocnemius, then soleus, And then you've got Flexor digitorum longus right here. Well, I almost missed one. And then we got this guy. So anterior tibialis, well, here's posterior tibialis on the posterior side here. Or you can call it tibialis posterior, either or. Either or is fine. And this one also is deep to soleus. All right, last one to label tonight. Here it is, and it's not a muscle. Booyah. Patellar ligament, or the quadriceps tendon. Isn't that weird how we name that structure? One's a ligament and one's a tendon, but yet I thought ligaments attach bone to bone and tendons attach muscles to bone. And it all depends, because the kneecap is a sesamoid bone, and a sesamoid bone is defined as a bone that sits inside of a tendon. All right, but also at the same time, from the patella down to the tibial tuberosity, all right, there's no muscle in there. So here's the thing. If you see, I'm usually pretty easy at grading this, but if you see the arrow pointing here, all right, I won't mark you wrong if you say quadriceps tendon or patella ligament, but if it's up here, okay, up above the patella, all right, definitely put quadriceps tendon, because that's where the muscle, I'll show you a better picture. There you go. If the arrow was pointing to this part here, okay, that would be the quadriceps ligament, or tendon, excuse me, quadriceps tendon. Yep. But down here, I'll accept both. So if it's below the kneecap, if you put patellar ligament, you're not wrong. If you put quadriceps tendon, you're not wrong, because it's a sesamoid bone. If it's above, you can see that it's muscle attaching to the bone. That's definitely a tendon. So that's going to be the quadriceps tendon. Okay. That's it. We done. Any questions? All right. So we have covered all the material for your third lab test. Please use the Quizlets. Take the mock exams until you can't stand to look at them anymore. All right. Pound that material into your brain. Make sure you sign out for me, please. I'd appreciate that. And I hope that everybody has a wonderful night.